what I always like doing with my presentations is to start off on the first slide telling you everything I want to impart to you, so if you want to fall asleep or check your email, you can go for it. And so what we've done before, and Jeff did an excellent job, is detailing how we get these very excellent quality images, typically with contrast enhancement, showing a moderate stenosis and ulceration. And where a lot of researchers have gone over the last 10, 15 years is saying, can we figure out what's happening in the wall, and does that predict, give us more prediction of risk for the future? And the short on a T2, the dark area is necrotic core. The bright area on time of flight, or T1, is intraplaque hemorrhage, and those are the things we're going to look for. Now, I will be explaining all of those to you and how we see them and what the risks are associated with them. I'd like to acknowledge government research funding. I've recently moved from Michigan State to Walter Reed as a civilian neuroradiologist, so these are Department of Defense disclaimers, so everything I'm presenting is my ideas and not the Department of Defense. What I want to go through with you is what's in the carotid wall, or the plaque, how do we interpret it, and why do we care? So first, there was a group of really excellent researchers going through and from the American Heart Association, understanding what is a vulnerable plaque and a vulnerable patient. And although there's a lot of complexity in this, from an imaging standpoint, there's two areas that we can readily identify that researchers have shown us, and that is early in the stage is a lipid-rich necrotic core. And the best way to explain this is basically a pocket of pus sitting in the wall of the carotid artery. And we can see it like we see pockets of pus anywhere else as a non-enhancing area with an enhancing rim around it on a T1 weighted image. If we don't get that lipid out of the plaque, we don't delipidate it, it continues to be there. Activated macrophages continue to come in, neovascularity continues to come in, those vessels are very friable, they leak, and you get intraplaque hemorrhage. So the first thing I want you to kind of take away from, admittedly an oversimplification of a very complex area, is the early stage of bad plaque, a vulnerable plaque, is necrotic core, pocket of pus sitting in the wall of the artery, and the late stage is intraplaque hemorrhage. And so this was one of my first examples. While I was at Michigan State, a patient with 82% stenosis was not symptomatic. That slice shows you the images that we obtained. These were some of the dedicated research images that I had access to via the University of Wisconsin, University of Washington, and Tron 1. And although it sounds complex, really all it is T1 weighted image, T2 weighted image, time of flight, contrast enhanced T1, kind of pretty basic kind of stuff. Where the magic is some of the multiple software packages that are available that allow you in research mode to do a pixel by pixel analysis and predict what the various plaque components are. What I've done here is taken the markings off of the T2, and this large area that's dark on T2 was the non-hemorrhagic necrotic core. And then what we did, I participated in a multi-institution histological validation study that showed that this area that's dark on, didn't enhance on post-contrast T1, dark on T2, corresponded very nicely with histologically validated necrotic core. So when we say dark on T1 non-enhancing area is necrotic core, we have histological proof behind us. So of course, as imagers, this is what we think of as carotid stenosis. This is what vascular surgeons think of carotid stenosis, and the surgeon I worked with the most excised the specimen completely intact. And one of the first questions he asked me is, can you make your luminal images look like what I think of to help me plan where I'm going to be doing my incision? So one of the first things we developed was simple volume rendering of the 2D imaging that we were getting of the plaque here. We decided, sure, the lipid-rich necrotic core should look like chicken fat yellow. And so although admittedly these look a bit cartoonish, they're actually based on a very rigorous science, and I find it's the best way in research mode to get across complex plaque anatomy to a clinician, and you're going to see I will use these a lot through the rest of the presentation. So this was all very interesting and occupied a good part of the last decade of what I was doing. And then John Houston and others really encouraged me to say, okay, it's really nice. Let's move this out of the lab and into the clinical environment. So much like Michael Hope talked about this morning, and I love coming here and seeing how different minds kind of come to the same point independently. We really got to move this out into the clinical environment. We got to use clinical sequences, clinical coils, no fancy software to analyze, and then let's ask a couple of good questions. So part of this was, okay, most of the major manufacturers now offer a 3D fast spin echo, variable flip angle T1 weighted sequence. So let's try using that before and after gadolinium, and let's see how it correlated with our research images. And I don't have time today to show you, but basically they correlated very well when the plaque components were identifiable and fairly large. If they're only on one slice, hard to see. So this is after contrast enhancement that we just gave for our contrast MRA. And again, this is a standard clinical sequence that's available to all of you at 1.5 or 3 Tesla. And what you see is this large non-enhancing area, pocket of pus in the carotid core, bilaterally involving the carotid wall. And what I did, these start off life as a coronal plane to help with getting the black blood suppression, and the multiple echoes help with that as well. And then we just simply reconstruct them into the axial plane, and I have this animated GIF just to give the idea of the image quality over a large field of view. So that's how we can identify the early stage. Now we're going to look at the late stage. As was already mentioned, any image that gives us T1 weighting can see hemorrhage. There's some nuances, but basically intraplaque hemorrhage looks like methemoglobin, so it's bright on T1 weighted sequence. So time of flight can see it, fast spin echo T1, MP rage, as we showed in our radiology paper, was the single best way of showing it, and this was from our paper, and this illustrated a worst case scenario where this large area of intraplaque hemorrhage had these large calcifications intersposed in there and caused these two sequences to lose some of their signal intensity, the brightness of hemorrhage. But basically, we again have good histological correlation. When it's bright on any of these 3 sequences, again, MP rage is the best, you can take that to the bank that there is intraplaque hemorrhage. So again, that same 3D fast spin echo sequence that I use post, well, let's just run it pre. And again, we get this excellent blood suppression. We can see the intraplaque hemorrhage. We also do an MP rage sequence. Again, you can just pull out your standard 3D FSPGR sequence, one that allows some sort of fat suppression, and then an inversion pulse to null out the T1 of flowing blood, and you can see the intraplaque hemorrhage. And so again, it's readily available. This was an interesting clinical patient, a 65-year-old woman. She presented with transitory contralateral arm and leg weakness. And so the clinician was worried, oh, maybe this was a stroke or a TIA. Did an ultrasound in his lab, in his office, which just showed less than 50% stenosis, and he was thinking, maybe it's seizures, could have been a TIA. Because he knows we routinely offer plaque imaging or vessel wall imaging as part of our clinical carotid MRA, he sent the patient to us, and we indeed did confirm. When you measure this diameter over this, even though that looks terrible, it was actually only a 30% stenosis. We know it's ulcerated, so we know we're kind of worried about it, but it's agreed with the ultrasound, less than 50%. But what you see is this area of intraplaque hemorrhage peripherally, and then right where this ulceration is a large clump of the intraplaque hemorrhage, and you can see where the fibrous cap got ruptured, and that's why you had in the carotid core. So this is an example. My segue into the clinical why clinicians care is now we were able to do a better job of assessing risk for the patient and the clinician. The ultrasound just said less than 50%, and he kind of would have blown that off. Knowing there's an ulceration, knowing there is hemorrhage right next to the lumen, he now considers this the likely source, and so now the patient is being treated with intensive statin therapy and antiplatelet therapy. And so that's how I kind of like to segue into why do we care about this? And it's because it does a better job of predicting risk with plaque imaging than simple carotid stenosis. Now, admittedly, right now, the only randomized clinical trials that we have to tell a patient and a surgeon whether he should operate or not are the NASCET trial and ACAS trials that were referred to earlier today. But the good clinical questions to get the data, as Michael had mentioned earlier, that we're trying to ask is how can we use plaque imaging to change patient management? And in particular, the two questions that we're going to be asking is patients with this large necrotic core, this pocket of pus you see as a non-enhancing area like I illustrated that we can see clinically. When we find that in asymptomatic patients with mild to moderate stenosis, maybe this group of patients should be given intensive statin therapy, even though current AHA guidelines would suggest that maybe this person only needs mild or moderate statin therapy. And the other test that we're going to do is to ask the question, what if you already have symptoms and you have that late stage finding, intraplaque hemorrhage? Those are patients we're very worried about. And so there, what we're going to do is treat them not only with intensive statin therapy, which is usually AHA guideline recommended, but now we're going to add a second drug on, the new PCSK9 inhibitors, which interacts with the lipid metabolism in a different way than statins and lowers the LDL levels even more. And this is very important for the government because these have now, one of the two drugs commercially available in the United States has made it onto the military pharmacy, but it costs over $1,000 a month. And so they are asking us to be proactive and say who should get this very expensive drug. And so one of the tests we're going to be doing is to say, we think this is our most at-risk group that we ever see, and that's the group that we're going to test. So what we feel is that the role of lipid-rich necrotic core has been well analyzed in a meta-analysis by Gupta, reviewing 9 studies, almost 800 patients, and clearly showed that large necrotic core was associated with an increased risk of future stroke, or TIA. We participated in this study called the carotid atherosclerotic score, kind of based on coronary artery calcium scoring, where we take complex ideas and try to simplify it. When you don't have much of a wall, less than 2 millimeters, it's a 1. If your wall is thicker than 2 millimeters, you look for the slice where the necrotic core, that pocket of pus, is the biggest, and the cross-sectional area of the necrotic core compared to the cross-sectional area of the rest of the plaque. When it's less than 20%, it's a CAS2. When it's between 20 and 40, it's a CSA3. And greater than 40, this is what people usually consider large, is a CAS4. So what we've done is applied that score prospectively in a couple of different studies and nicely showed this increased plaque progression. The more you got, the more you got. So the CAS4s with big plaques continue to progress very rapidly, and the patients that have a CAS score of 3 or 4 at baseline were the ones who went on and developed new ulcerations or new intraplaque hemorrhage, and in a study not yet published also had new stroke and TIA. So what we're trying to do is take a complex area and make it like a simple score that you can assess risk for. So we think that the large lipid-rich necrotic core, the CAS4, is the phenotype of atherosclerotic disease that's very amenable to medical therapy. And Dr. Shishau and others, cardiologists and others at the University of Washington, put this to the test by giving patients in a double-blinded fashion standard statin therapy and intensive lipid-lowering therapy. And what she demonstrated very nicely is this is a non-contrast. This is the T2, so admittedly the necrotic core is harder to see, but it's basically this whole big dark area, this huge, on multiple slices, big necrotic core. And what happened was this patient was put on an intensive statin and then followed for 3 years, and you can see that the necrotic core shrunk, and in this case, the actual plaque thickness got better. So we have very good evidence that we can delipidate. We can take the fat out of the plaque and take the risk away and keep them from progressing to that late stage intraplaque hemorrhage. Our own experience from Michigan State early on, again, the yellow, if you remember, is the area of necrotic core. This patient was asymptomatic and was not operated at the time. The patient was on a moderate intensity statin, had achieved an LDL level below 100, which at the time was considered guideline therapies. Despite that, the patient continued to progress. The yellow area, the necrotic core, doubled in size. The stenosis became worse. Thank goodness he didn't develop symptoms, and he went on for carotid endarterectomy. This example was the first one that really piqued our interest and gave us the idea that maybe we could delipidate, maybe we could take the plaque out. This patient had been on the same dose of a moderate intensity statin for 5 years before this study, and he came to us in 2005 and had this huge necrotic core. Very interestingly, he changed jobs, he got better medical insurance, and he was able to now afford an intensive statin therapy. Not because we were smart back in 2005 and thought that we could do better, but total serendipity. And so we invited him back the following year, and his necrotic core got a lot smaller, and then a year later went completely away. Now, admittedly, usually responses aren't this marked, but it gave us the idea that perhaps we could use imaging to find the subset of patients who are the most at risk, the CAS4s, the big necrotic cores, and follow them to say whether their statin therapy is getting better or not. In the same way, the intraplaque hemorrhage is the end stage of vulnerable plaque, and Tobias Sam reviewed 8 studies, again, about 700 patients, and he found there was a 6-fold higher risk of future events with an annualized event rate in subjects that did have intraplaque hemorrhage of almost 18% compared to a little over 2% if you didn't have plaque hemorrhage. And that risk was particularly significant and worse if you had had recent symptoms. So that's why we think the combination of recent TIA or stroke and the finding of intraplaque hemorrhage is a marker of a very vulnerable plaque, which is why that second study that we're going to ask with intensive statin therapy, adding on the PCSK9 inhibitors. I didn't have PCSK9 inhibitors. They weren't actually commercially available in 2010. So what had happened is we'd been following this patient for 3 years, and I was just dutifully describing how his intraplaque hemorrhage was getting bigger and bigger, and we were just very uncomfortable, yet he met guideline therapy at the time. This is considered an intensive statin therapy and an intensive dose, and he had achieved an LDL of less than 100. Talked to the vascular surgeon taking care of him and said, you know, I'm really worried about this. Let's up his Lipitor to 80. He tolerated it well. It took a couple of years, but we were able to modulate that, and after watching it grow, we were able to knock it back down. And we believe, and now this is what I need to prove in a large multi-institution study, that this patient is going to be at less risk with his intraplaque hemorrhage going down than he would have been if we just continued to let the plaque hemorrhage grow. And so this, I think, is another powerful tool for vessel wall imaging. So what I wanted to do with you this afternoon is to go what's in the carotid wall, or the plaque, necrotic core, pocket of pus, non-enhancing area on contrast-enhanced T1 early, intraplaque hemorrhage, looking like hemorrhage anywhere else, bright on T1. Why we care about this is we feel that patients with large necrotic core that are asymptomatic with mild to moderate stenosis are the perfect subgroup to give these intensive statin therapies, especially Lipitor is off a patent now. It's very cheap, less than, it's like a couple of bucks a month, and so we're going to try to do this in a tri-service research agreement across the VA hospitals. So we have some discussions, and see if we can improve patient outcome. The second group is we're going to look at intraplaque hemorrhage in symptomatic patients and add intensive statin therapy with PCSK9 inhibitors. I deliberately didn't give you any specific protocols or techniques on how to do this because you can do it in research mode, you can do it in clinical mode. I reference you to this February 2016 neuroimaging clinics where the entire book was devoted to plaque imaging. Thank you very much.